So today's session is our second episode, and it's titled "Into Thin Air: Physiology of Altitude." And we are honored to have Dr. Matiram Pun, a PhD, as our speaker. He is a Nepalese physician and high altitude medicine researcher who is currently based in Canada. He is alumni of Institute of Medicine. He completed his medical training in Nepal and went on to pursue his master's in science and PhD in hypoxia, altitude, and sleep breathing disorder at the University of Calgary, Canada. And also, he's a longtime member and a former vice president of Mountain Medicine Society of Nepal, and also a former assistant professor of clinical physiology at MMC. So to mention that he has played an important role in mentoring young MMSN members and young physicians like us into this mountain medicine. And over last decade, he has focused his work on high altitude shift works in South American Andes of northern Chile. And we are truly privileged to have him with us today. Welcome, Dr. Matiram Pun. The platform is yours.
All right. Okay, Suraj, thank you very much. Thank you guys for bearing it. So a little bit of mismatch in timing, but we'll get going. Anytime you want to stop and ask questions, please feel free to do so. Um, so this is the outline of the talk. Basically, we'll talk about altitude here primarily, because this is we thought that would be the synonymous of into thin air hypoxia altitude. Although hypoxia can mean different settings and categories, here we try to focus on altitude. Um, so if you look at that, if talk about altitude, there are different geographical locations or altitude ranges around the world where people frequently visit from lowland, or there are high altitude residents. The big ones are Himalayas, where Tibetans and Sherpas permanently live, and then another one is South American Andes. There are also Ethiopian highlanders in Africa, and there are other locations where people go to work or for commercial and recreational purposes. Um, so basically, who are the people that resort to the altitude? Basically, they are trekkers, climbers, but also those people who do for professional reasons for living, for such as miners, conference attendees as well, and porters, and other type of workers. There have been some researchers who have been going at altitude, for example, observatories, astronomical observatories, and also research stations such as South Pole, where there are military and astronomical significances. In Nepal and Tibet, there are pilgrimages as well. So these are a large group of populations who travel to altitude for pilgrimage purposes. Then, of course, there are high altitude residents in Nepal Himalayas, Tibetan Plateau, South American Andes, and Ethiopian highlanders. And there are also Kyrgyz highlanders. This had been relatively less studies, but there have been some mining industries in that area, and people go to work. That has been a major focus in recent decades. Um, with the development of transportation and access, there are also migrations, internal migrations within a country, where the lowlanders travel to altitude for the work as well as residential purposes. For example, in Tibetan Plateau from the lowland China. When you go at altitude, basically what it happens is there is the barometric pressure becomes lower, and the partial pressure of oxygen we take becomes less. The percentage of oxygen in atmosphere remains constant, but due to elevation in the altitude, the barometric pressure goes down, and that leads to the lower partial pressure, the pressure of oxygen that exerted in our lung, that and also dissolved in our oxygen in our blood becomes less. This is the primary reason why we get less oxygen at altitude. But also into thin air, if you synonymously talk about hypoxia or less oxygen, that can happen in a number of other conditions. For example, when you do intubation in ICU or give anesthesia, and there is a lag time, you are able to intubate and oxygenate them. That's also a hypoxic period. But there is no barometric pressure decrease. It's just a normal barometric pressure. You just don't get oxygen. It's suffocation sort of thing. Similarly, there are lots of people nowadays, and also recently appreciated in last few decades, that people suffer sleep apnea, obstructive sleep apnea, or other types of sleep apneas where they stop breathing or close to stoppage of breathing, and they suffer a brief period of less oxygen during sleep. Then they quickly start breathing, and they oxygenate a normal level. Then again they fall back to sleep, and they have another episode of stoppage or close to stoppage of breathing. That also leads to overnight a number of times of um, desaturations or less oxygen. We call intermittent hypoxia, or commonly known as obstructive sleep apnea or central sleep apnea, in those conditions as well. And then other conditions you might you guys know that COPD and other conditions where there is less oxygen as well. So oxygen deprivation in medical conditions and also normal routine life in the general public, in a general population where we are normally living and working, is also common. So to going back to our main topic, altitude, what happens is air pressure around us is obviously filled with high density with different components, nitrogen is. So when we elevate, go to altitude, and we are just going from the above the Earth's surface, and the pressure above us, the column of air on our head becomes less and less. And that pressure, that less pressure is barometric pressure, and that pressure, when we go at altitude with the less pressure, there are less number of molecules around there. That is partial pressure. This is the primary illustration of in a general public way to illustrate how this happens at altitude. So to come back again to altitude, so what is the equivalent? How much equivalent percentage of oxygen is less when you go at altitude? If you are living sea level, Goa of India, or maybe where Santosh is living in Caribbean Islands, or Washington, Seattle, or somewhere else, or Vancouver Beach, that would be sea level. And low altitude is 500 meter or so. We can classify 1,000 meter and below is a kind of low altitude. In that classification, Kathmandu around 300 meter, 1,300 meter altitude will be, and Calgary, where I am right now, is 1,100 meter, slightly higher. And then 2,000 to this around that altitude is about is some Park City, South Lake City, Utah. You can see there is about 16% oxygen, and and it's sea level FiO2. That is what it would look like. And then if you go at a higher altitude, 3,000 meter altitude, is kind of 12%, and then 5,000 it would go it's about 8%. And then linearly, what it impacts in a very simplistic manner is your VO2 max, which is the maximal oxygen consumption capacity when you do exercise to your max, is reduced linearly up. Well, it's almost 100% at low altitude sea level, and when you go about 2,000 meter altitude, 6% less, and then 3,000 meter around Namche Bazaar, which is 3,500, it's 30% less. It's basically your capacity to do maximum exercise or work output is reduced. That's what it means. So Uh, and then even more simplistic way to understand is how much oxygen will be in your blood. At sea level, obviously, we expect 100% unless there is any condition. And if you go at altitude, 2500, which is definition of altitude, we define altitude is anything above 2500 meter and altitude. It doesn't mean that if you go at 2500 meter, you will get hip, haze, or a headache immediately. It obviously depends on a number of parameters, your physiology, your personal response to the oxygen, less oxygen, and all that. But the overall definition, altitude, somewhere we can feel altitude and our physiology starts responding, is 2500 meter. Your altitude of your born and raised, these are all genetics, all play role. And 3500 will be around 80 to 88% of saturation. So if you are Namche Bazaar, if your saturation is around 88, 85%, that's expected in that altitude. So Faraday around 4,000 plus, and you know that then you might have like 25% reduction of altitude. At base camp, uh, almost 30% reduction. So that 30%, 25% is huge a decrease in your oxygen saturation. And if you do exercise, and then you will obviously aggravate. But if you carry a load, obviously that's a part of exercise because you are exerting stress in your physical capacity. That will also increase or put at risk. So yeah, so Crocs up. Do you have any questions? Do you guys want me to go faster, or is it okay, Suraj and Suman?
I think the pace is completely fine,
Yeah,
Suraj.
okay. Yeah, so I'm just going to the physiology now. The crux of physiology, what it happens, the first thing is our ventilation, breathing becomes deeper and faster, which means we take a lot of air and also we increase our frequency. We are trying to max our capacity. When your baseline ventilation, minute ventilation, which is tidal volume into frequency, is there, is somewhere here. As soon as you get hypoxia, less oxygen, your ventilation goes boom, high. SVR is hypoxic ventilatory response. It basically means when you are getting less oxygen, your breathing or your frequency and volume increases, and this is we call a hypoxic ventilator response. Somebody asks, "What is your SVR?" And if you have a good SVR, is will you be able to acclimatize better or not at altitude? This is initial response. It goes big, and then after a few minutes, like 10, 15 minutes, it slowly comes down. So we call this is SVR, and it has two response. If you don't respond this is bad. That means your system's capability to defend against hypoxia is not there. Where does it come from? There is a carotid body in our bifurcation of common carotid artery, small collection of cells, and these are the sensors, the powerful sensors of less oxygen. That senses partial pressure of oxygen when it goes down, and that manifests with a number of responses. And the biggest and the best response, and we can quantify and say, is ventilation. And the response we call hypoxic ventilatory response. After 10, 15 minutes, it slowly tries to come down, and that we call hypoxic ventilatory decline, SVD. And this is based on the peak versus where it stabilizes in 10, 20 minutes. This is SVD. After that, you kind of stable, but you have to have a certain level of higher, but also not a very peak, and then it stabilizes. After a couple of days, then it might increase or remain slightly similar. And this is called ventilatory acclimatization. So that you are digesting at altitude, you are getting used to with altitude. Um, and this should last long, and this is where it comes your acclimatization. That's why we trek altitude and give extra days of acclimatization, and we trek slowly. If you go very fast by a helicopter or a cable car or a car, these times are not allowed. So before a ventilatory acclimatization comes, you're already up there. So yeah, so uh, because corroded body is there to master sensor and respond, and you can see a number of physiological responses. For example, here, cardiac output, cerebral blood flow. Cerebral blood flow means the blood flow to the brain, and heart rate, and means systolic blood pressure, pulmonary artery pressure, and sympathetic activity. You can see initial response is big, so that's why you don't want to go too fast, because your initial response will be even bigger, and before it comes down you are already high. Your system is really cranking up. So if system is cranking up, there are chances that it is not well, it cannot acclimatize that the rapid ascent. So where we can suffer altitude, and you can see sympathetic activity remains high, and I will come back later. Sympathetic activity, so sympathetic activity can be measured with a small needle sticking into the peroneal nerve just below knee and giving hypoxia. And based on that, and if you go hypoxia and less oxygen, and if you measure the sympathetic activity, the firings of nerve and the amplitude, the frequency and amplitude, the response, the how big is the response, how fast is the response, these are increased. If you see sea level, you can see in the far right side, this is the normal response, like small few spikes and all that. And if you look at 5,000 meter, like a big responses. So this like constantly firing. So if sympathetic nerve is firing constantly, your blood pressure is high, and other systems are also responding in same way. And even if you descend, then still there is sensitization. This is where the carotid body and sympathetic activity increase. This is the primary drivers of altitude. So what are the normal responses where I should be worried, and why this is it a am I getting altitude sickness, or this is normal? Obviously, ventilation, it is supposed to increase. And also, let me tell you guys that there are kind of, we call responders and non-responders. So some people respond very good and big, and some people don't respond that well, and some people don't have response as well. Obviously, if you remove carotid body, if your carotid body is removed by some radiation operations or neck operations, and your ventilation won't be good. The hypoxic response won't be there, which is not good because you are not sensing the danger. It's something like that. There is a smoke in the house and you don't feel smoke and you don't feel like running away. So that's so ventilation deeper and faster, cardiac output increase and basically driven by heart rate, and hemoglobin concentration within a few hours to a couple of days. This is primarily due to your dehydration and this breathing and all that. But the actual formation of red blood cells by increasing erythropoietin response will take few days to weeks. So it won't be that fast. And then obviously, when you increase ventilation, there is a respiratory alkalosis that needs to be corrected, acid base, by the help of kidneys, and that comes as an effect of diuresis in normal behavior. As a layman's terminology, you are just going pee more. And these are all part of the process of defense to increase oxygen saturation for our body. And the same thing has been illustrated with figure way, cerebral blood flow, ventilation, which is hyperventilation increase, and pulmonary artery pressure will slowly increase and crank up. Will come about pathophysiology later, cardiac output, heart rate, and basically first response is high and brisk because it senses, okay, there is emergency, let's crank up, and then slowly it will stabilize. And all of this erythropoiesis, as you know, that this you might have seen a lot of athletes do go to altitude or get hypoxia to train. It doesn't come immediately. Everything like ventilation came very quick, and the cardiac output, heart rate came quick. But erythropoiesis, you can see later in a month, with days to months. So that's something. And muscle density. So training effect can take a longer time. The whole idea is that you go a couple of days and you are not increasing your VO2 max and not winning gold medal or something like that. Uh, uh, so if you look at this oxygen dissociation curve at altitude, basically this is a sea level. If you look at that x-axis here, so 3,000-meter altitude here, you can see this is where the curve is, and if you look at this, this is where the 5% decrease here from this altitude to this altitude, and this is somewhere in 3,500 altitude. But if you go higher altitude, the dissociation curve comes in a steep region. There is a rapid decrease. That's why there is extra resting days at Namche and Feriche, but not at somewhere in a Lukla, because you are in the flat curve this side. Once you are in a steep region, you need to let body to acclimatize, because you are in a steep zone. As soon as you get altitude, your desaturation falls rapidly. And also, you need to decrease the rate of ascent. Higher you go, the slower and give the body. This is the physiological basis. Uh, so for those who are in a basic science and also the physiology, alveolar gas equation is extremely important. As you know, inspired partial pressure of oxygen at particular altitude can be calculated with the percentage of oxygen, 21% at sea level, and barometric pressure, PV, and water vapor that's subtracted. And then how much your alveolar end tidal oxygen you are getting can be calculated with inspired partial pressure of oxygen with partial pressure of carbon dioxide and respiratory quotients. This is sort of the crux of physiology in hypoxia. So this is kind of basic physiology, guys. So we are coming back to the clinical now, more fun part. Probably that's the more boring part. Pathophysiology of altitude illness. What are the altitude illnesses when you go to altitude? There are a few entities, and as altitude sickness is a spectrum. And first thing, as you go, and many of you might have gone to altitude, but if not, the best and the fastest and cheapest way is to travel to Gosaikund. So have a day back, a couple of days weekend, or have a long weekend. Go to Gosaikund. Just take a bus to Donche, from Donche to Gosaikund, and feel the headache and enjoy the lake and feel the headache. That would be the best exposure, because you won't have the chamber there to expose yourself hypoxia. And if you go to Everest, it will take a lot of money, a lot of time, and other expeditions will take others' help organize. But going Gosaikund will be the your own excursions. So if you go at Lowry Bina, which is 3,900-meter altitude, you might start having headache. High altitude headache is sometimes considered as separate entity, sometimes not. But we often consider AMS, which has headache as a must criteria. So severe headache qualifies almost like AMS. So if you score severe headache out of 1 to 3, scale 3, then it will be AMS. And then high altitude cerebral edema is the swelling of the brain. High altitude pulmonary edema, that will be the water collections in the alveoli. And basically, because we'll go pathophysiology a little bit later. And then there is chronic mountain sickness. In the left, this diagram, pathophysiology of altitude illnesses, AMS is a big circle, that is incidence and prevalence of AMS is very high. And I would say headache will be bigger circle than AMS, because many people will get headache but will not qualify as a criteria of AMS. But AMS must have headache. So all of the people who have headache and plus other symptoms will qualify for AMS. And then most of this AMS, when they are not treated or people keep on ascending, then it'll progress to HACE. The HACE is high altitude cerebral edema. That's a brain edema. And then HAPE is almost separate entity. Is not almost the pathophysiologically it's a different entity. So you can see there the circle you can see bigger than haze. So that means the prevalence, incidence, and prevalence of HIP is higher than haze. Which will surprise you that many of you who have been going to altitude and Gosaikun, you might have seen a lot of haze or might qualify haze, but not HAPE in Gosaikun. But in a historically, HAPE is more prevalent. So clinical picture of altitude illnesses, but the physiology is like this. Clinical picture looks like almost overlap. AMS and haze obviously overlap. HAPE and haze and AMS almost overlap, but a little bit of overlap. So what it says that when you have a HAPE, the symptoms, clinical symptoms, are there overlapping, sharing symptoms with haze and HAPE. People who have HAPE pathophysiologically, mechanistically might be different, but they will have headache, dizziness, nausea, vomiting, and fatigue, tiredness, all these things. So they will be shared. And some HAPE may not have the symptoms of AMS or haze, but they will have isolated HAPE. Okay, so this is something to keep in mind. Pathophysiologically different entity, but clinical spectrum, if you treat a patient, take a history, take a clinical features, they will be similar. Okay, so who gets? Obviously, those born and raised at lowland. And why? If you go too fast, too high. And what is the solution? Obviously, you don't go at altitude, or if you are already there, stop ascending or slow down to allow the rate update. And why? Because you just don't let time to acclimatize. This is another picture. You guys might be very well or aware of this picture. This is in Lancet in 2009 by Chris Embre, who climbed Everest in 2007 in a caudal extreme Everest, and Mark Wilson from UK. They wrote a nice review about several features of this haze. This is the rate is somewhere there. It just lists the number of features at altitude where the symptoms starts appearing. This is altitude in meter. This is partial pressure of oxygen. Sea level 150, and then symptoms, and then you can see the high altitude, very high altitude, and extreme altitude. Psychomotor impairment, decrease in all these cognitive functions, learning and spatial memory impaired, very high altitude. So these are the altitudes. So basically 7,000 and above, they call that loss of consciousness and dizzy. This is obviously if you do the rapid ascent, the acute decompression from aircraft and explosion, all that. If you are flying at the level of Mount Everest and there is suddenly pressure release for the plane, then you get acute decompression sickness. You might be asking who flies above the Mount Everest? Obviously, bar-headed geese. Also, our plane that Boeing's fly much higher altitude, but they are under pressure cabin. If by any reasons, if the plane's cabin pressure falls, then we can suffer this acute decompression symptom as well. So so how do we know how these symptoms? And then I will briefly talk about how these scoring systems came into and how it went through. How are we doing time-wise, guys? Do I need to go faster? Suraj, is
Sir,
it okay?
I think we need to conclude the session in maybe about 10 minutes now so that we can have some time for a quick Q&A session as well.
Right, right. Okay. So yeah, so in 1991 there was consensus in Lake Louise in a hypoxia international hypoxia symposium meeting, and where there were a number of clinical symptoms were listed for acute mountain sickness and high altitude cerebral edema and pulmonary edema to score them, and then this was where these scores were designed, and then they were formally concluded in 1993. That's where we come with the score, acute mountain sickness score, Lake Louise criteria. Obviously high altitude headache, there is obvious it can be any part of that, and ascend altitude with the premise that you are at altitude, and acute mountain sickness will must have headache to qualify. So this Lake Louise criteria has been revised in 2018. The sleep component that was included in 1991 and finalized in 1993 has been removed because many people and many of the studies were done in normobaric hypoxia or in a day ascent, and there is no sleep at altitude, and it didn't make sense for those situations, and then we remove. Headache, how does that headache come? As you know, guys, the brain is insensitive to the pain, but how do we get headache? Basically, we think that there is triggered by the activation of trigeminal system. So there is hemodynamic increase, stretching of the blood vessels, and activation of trigeminal system. This is where it comes headache, and obviously other symptoms of hypoxemia comes from. So then that is headache and Lake Louise. Now, if you don't treat them or descend or take oxygen, then it will progress to the high altitude cerebral edema. Basically, when it happens that there is hypoxia, increased blood flow to the brain, and then increased blood flow to the brain is also accompanied by the reduced venous outflow from the brain, and that will lead to the stagnant of the blood volume or the brains in the inside the skull, and also there will be accompanied swelling of the brain. So that increases overall the swelling of the brain as well as increased ICP, intracranial pressure. That will lead to increase this pressure and vasogenic edema, also leakage of the fluid and vascular endothelial growth factor. This is how it leads to the swelling of the brain and the subsequent presentation of the symptoms. And there are various molecular pathways we proposed: VEGF, vascular endothelial growth factor, hypoxia inducible factor, and this is the progression of AMS. Basically, increase hemodynamic response initially, and then followed by the VEGF, other vascular components. There was some normobaric study done by Sagu et al. With the Chris Imre's team. Here also, validating the hypothesis. They had the increased hemodynamic response, increased blood flow, decreased outflow of the venous, and brain swelling. So if you have a tight brain, young brain, or there is other reasons that the skull is tight, so even slight increase in hemodynamic with altitude increase the swellings and symptoms. And if you are like there is a little bit of capacity, like aging brain, then there might be a little bit of space to swell, and you might not get symptoms. That's why we kind of anecdotally explain that older individuals might not have that high symptoms of acute mountain sickness, cerebral edema. Then obviously there has to be mental status change in mental sensorium ataxia for this high altitude cerebral edema. For hip pathophysiology, is there have been a lot of work, and basically it is increased pulmonary pulmonary artery pressure. With the hypoxia, less oxygen, there will be increase in artery pressure or pulmonary vasoconstrictions in our pulmonary arteries. The unfortunate part is, or fortunate part, that not all arteries are constricted. There are some arteries constrict, some arteries don't. So the pressure in the arteries that are constricted is high, and then you are at altitude, increased blood flow, and then what will lead to that? That will lead to increase in the leakage of the fluid. So basically, when you do this hypoxia, there are some vessels are increased, and then if there is increase, and there will be leakage of this fluids into the alveoli. So this leakage will lead to the accumulation of fluid in alveoli, and where you might have this funny sounds of the gargling, and then the pulmonary edema. Obviously, if you have a fluid in the alveoli, your the oxygen transport is not going well. This is where the physiology behind the hip happens. And then right after your leakage of fluid or vascular leakage, there will be some leakage and also damage in the endothelial cells, and there will be some macrophages will coming, and then inflammation will be following. It is not inflammation in first hand, but right after this leakage, and there will be inflammation. So if you do the bronchoalveolar fluid, then you might find that. So Lake criteria, obviously you need to have a dyspnea at rest cough, and you might have pink frothy cough because there is a leakage of the fluid, and there might be blood in that cough, slight tinge. And then crackles, wheezing, because there is a fluid in the alveoli. And if you don't get, because there is a fluid in the alveoli, you will have a profound hypoxemia, and central cyanosis will be there. Now, prevention and treatment, obviously, this um, is we can read the HRA's flyers, guys, right before going at Gosaikont and Dunche. Um, this is basic. Don't go too high too fast, and listen to your body. Pharmacological acetazolamide is well tested and tried. Credit to our guru, Dr. Basnath, who mentored all of us, many of us, has done a lot of trials to establish acetazolamide roles. Dexamethasone is a magic bullet. Nifedipine, tadalafil, salmeterol are for HAPE. To summarize altitude illnesses, high altitude headache, 80%, many of you get. Acute mountain sickness, a third of them get. And cerebral edema about 1%, and hip 1% to about 2% in an average. Yeah, so this is the summary. I would like to end here and just open for the discussion. I think that would be the most important part for it. How do you think, Suraj?
Yeah, that was a great presentation, Matiram sir. I think like we all got the exact detail into the pathophysiology of acute mountain illness, HIP and HIS. We do have some questions from our participants from the Google form.
Is this in
So
Q&A?
also,
You can facilitate. I
yeah,
don't see.
also I want everyone to maybe ask question in chat if they have anything other than what has not been addressed by the presentation already. So one of the questions I think many things that has already been answered from the presentation. So one of the questions is, what are the major struggles while encountering trekkers with altitude medicine sickness nowadays? So, do you want to answer it, Matriam sir? Sorry, I cannot hear you. Hello, Sumanda, can you hear me?
Yes, Suraj, I'm hearing you.
Okay.
Matidai,
We cannot hear Matide.
you have a questions and we are not hearing from you. Maybe Suraj, can you repeat the question again?
Maybe you can answer, Sumanda. So one of the participants has a question like, what are the major struggles while encountering trekkers with acute mountain sickness nowadays?
We are not hearing from you, Matidai. You are muted. You are unmuted, but we are still not hearing you. Is that right, Suraj? We are not hearing Matidai, right?
Yeah, I cannot hear him.
Can you hear now? Okay.
Yes, sir.
Yeah, Suraj, I wanted to you to repeat the question. Sorry, that was a mess.
So like one of the participants wanted to know what could be the major struggles while encountering trekkers with AMS nowadays as a clinician or a physician.
Yeah, I think somebody who is at Feriche, probably they are in a better position to answer before me. So I would encourage somebody who has recently worked at altitude clinic. Maybe you guys can chime in, and I will supplement my hypothesis or experience.
Prince, are you there? Dr. Prince, are you there from Feriche? You can. What are the struggles are you facing when you have
Oh, well,
AMS patients up there?
hello. Hi. This is Dr. Prince, and I'm Dr. Joanne Lai. We're both volunteers at Very J 8 Post at the moment. Yeah. Do you want to start? Yes. Okay. So starting with the struggles that we face on day-to-day basis while we are dealing with acute mountain sickness and people over here would be first thing in last few weeks we had a snow blizzard when there was 3 days of complete no sun and only it was snowing all the day and our solar power, our batteries were completely gone out, and that is when we had two patients with high altitude pulmonary edema and one with high altitude pulmonary edema with cerebral edema. And at that time, we were really worried that our oxygen concentrators, which were the most important aspect of maintaining the oxygen saturation of the patients, would run out without cover, and we were concerned about operating the gamma bags. Like there were three patients at the time, and we would not be able to accommodate all the patients in the gamma bag at a time. And so yes, power outage, uncertainty of weather conditions, and similarly, the number of patients that the hospital can accommodate are some of the problems that we faced while managing the cases. And for the Dr. Joanne? I totally resonate what Prince has said. So this is the case when there's a problem with evacuating our patients because of bad weather or because it's nightfall. So it is not possible to get the patient down by helicopter or by the help of animal. And speaking of evacuation, the work of HRA is mostly to treat porters or Nepali guides who got acute mountain sickness or high altitude cerebral edema or pulmonary edema. We're still facing a lot of challenges trying to evacuate these patients because some of them work independently and not under a guiding or trekking company. So they do not have good insurance in order for them to be evacuated by a helicopter. And of course, right now in Nepal, the only kind of helicopters that can help evacuate patients are actually sightseeing helicopters, and we do not have a formal helicopter rescue service where sick patients can be evacuated at a free cost. So these porters, if they do not have insurance and or if they are not supported by their trekking companies, then it's very difficult for them to be evacuated down. We often have to ask helicopter pilots whether we can shove that patient onto that extra seat that they have on that helicopter, and very often they do it entirely out of goodwill and do not charge the patients. But definitely evacuation is a big problem here, and hopefully in the future there would be a more well-structured helicopter rescue services for porters and guides in needs.
Yeah, thank you, John and Prince. I definitely think the logistic and lack of oxygen, like the supply are the major struggles for the physicians treating at altitude, even at Everest year. So Dr. Pun, we have another question from Dr. Pratibha. So apart from the past history of altitude illness, are there any other tools which can predict if someone can have another episode of acute mountain sickness or high altitude illness?
Yeah, Santosh wanted to say something.
Yeah, I will to that. I've actually watched previous discussion. Like I was saying, so right now traveling to Feriche is Manang, right? So the medical insurance or that is mandated as instead. Like the evacuation insurance, right? It's not mandate, right? So now we can I think now looking at the problem, of the evacuation and all, and I think it's actually we should advocate for. I mean, talking about the evacuation system. Did you get
Yes,
my point?
definitely. Yes, definitely. I agree with Santosh Dai. There should be a mandatory insurance system for our porter as well. But I don't think some of the porters they don't have mandatory. They get tied to the company later during their journey, and then they don't have. Some of the guides who get in contact prior to the event, they might get the insurance. But some of the porters they tag along the journey, and then they don't have evacuation. I think that is the case.
And what about the trekkers? Like for the foreigners, is it essential? Just for my interest, I'm just asking. Is anyone
uh,
aware of this?
I don't think it's still mandatory. Suraj, do you think it is mandatory? Did you see all of them having insured when they came to Everest ER?
Usually almost many of the cases that we saw were the summiters. So like all of them are insured, usually the foreigners, not the Nepali porters or even the local staffs working at Everest region. So I think it depends on the company that you are tied to while you are trekking to Everest base camp. Like if you are tied with a good company, they usually want you to have the insurance before you trek, but I don't think it's mandatory still.
Yeah, yeah, that's what I'm asking. If such problems exist and they twist the name of our trekking company, but that it has made mandatory by government. So there's no official saying with the documentation they have insurance, right? If I travel to I need to get insurance, right? Without I don't get visa. Like if I don't, but it seems we don't have some.
All right, and then next question was about whether we can predict altitude sickness, right, Suraj?
Yeah, so like apart from history of altitude illness, was there or is there any other prediction tool which can predict if we can have another episode of altitude illness this time?
Yeah, obviously history is the most important. If somebody had previously, and especially for a high altitude pulmonary edema, the history is telltale, and there have been works for the genetic basis of high altitude pulmonary edema in the Japanese populations, and also records from Switzerland. They had long records and recruited again for the studies of high altitude pathophysiology and prevention drugs for sildenafil, tadalafil by Marco Mazzurini and Peter Bass et al. So if you have HAPE, and which is fatal condition, this seems like you will have again if you go very high altitude. But for AMS, you cannot tell that much about that. And those people who are going for the first time, as I spent a lot of time explaining about hypoxic ventilatory response, this is sort of one of the markers that you can assess. If you have a very, very good hypoxic ventilatory response, you have a good response to the altitude. So you might acclimatize well if you give enough time. But also it might come as a disadvantage if you are climbing Everest. If it is extremely high SVR, you might be just going into a lot of hypocapnia because you are clearing carbon dioxide too much, and you might be having a lot of periodic breathing and bad sleep, and that might just come at a disadvantage. So if somebody doesn't have a response at all, which we call non-responders, or a blunted hypoxic ventilator response, this is almost saying that you will get headache or acute mountain sickness. Yeah, other than that, obviously, if you are not fit enough to walk up in the mountains, that'll be a bad thing. So some people who are proponents of exercise, and they think that, oh, if you are fit, exercise treats everything, and exercise is the only the panacea, and that's not true. If you are fit and this is good, you can walk up in the mountains, but it doesn't give you a license to run up the mountains or do and exercise a lot. So kind of, yeah.
Can I
Yeah, go ahead,
add to
Santosh.
what Dr. Matiram just explained? Beautifully explained, like people have been looking for a patient model right all the time, and we are very limited evidence on that. But I'd like to share, like I got one experience with one of the papers. They were doing like they were using urinary metabolomics. The different markers were actually being identified at sea levels because we have to predict it in sea levels, right? Right now, we don't have that modalities. So there's a lot of biochemistry in it. I was fortunate to go through those papers. Things are being worked, but they require like tandem mass spectrometry, which is not there. So it's actually being happening in there. The researches are going on. If someone's interested, you can look for urinary metabolomic markers for AMS prediction. You can get those papers. They are from USA. There's a group that work on that, and they're trying to predict different markers like urinary carnitine, urinary. There are a lot of markers that they are trying to utilize, and they're working on it. And then, of course, the second key thing is are the different genes, right? The genetic polymorphisms. Those can predict, but of course, we know we need to have an established genetic centers for doing those. So right now, being in Nepal, I mean, it might be a big cost issue for us, but hopefully they should be available maybe in 5, 10 years. We don't know.
Yeah, thank you, Santos. And also, guys, I would like to also emphasize that this research versus clinical settings are quite different. And research is by like we are trying to find one marker at a time. When you see the patient in the clinic, you see whole package, every marker from head to toe, every system. And sometimes people predict with one marker, with one other, and oh, okay, this doesn't play a role, or this plays a role, and which might not be implication at or translatable at the bedside. So hence the physiology research sometimes need to be taken in all of that perspectives. So uh, like when you see the patient, you see the all the systems involved. When people do research, they see one cerebral blood flow reactivity or urine metabolomics. That is a small portion of whole picture. So sometimes this research is, even though I do physiology research, I will claim that this is conclusions, all that might not be playing a big role or like explaining everything you guys see at the bedside or in the field.
We use such small sample for a research, right? I'd like to conclude that statement to 6 billion, 8 billion people. It won't work in general.
Exactly.
Matiram sir, so we have another question. Joan from Ferice had asked, till when does the effect of acclimatization remain after one has descended from high altitude, who has spent a substantial amount of time there to a lower altitude?
Yeah, fantastic question. Yeah, that's the very, very important question, especially for the mining companies, the workers in South America and Kyrgyzstan, and even nowadays in China, that people want to go altitude work, acclimatize, and also don't want to remain there all the time because this is continuous hypoxia. So they want to come down and go back quickly so that they are not losing acclimatization, but also not suffering hypoxia all the time. So 2 to 3 weeks window, we call that. And most of these physiological parameters and the hypoxic ventilator response, heart rate, blood flow, and all that, these are retained about 2 to 3 weeks, depending on the physiology of the person and all that altitude they are exposed, all that. But also to caveat, where may insert my area of interest, the sleep doesn't seem to acclimatize that fast and doesn't last long. So, that if you're doing that sleep, so that's another component. And sleep is extremely important. So sleep also is not 100% physiology. Sleep is behavioral problem as well. A lot of things depend on your behavior. For example, if you're drinking coffee, if you're watching television late night, or playing with the screen. So if you start implementing behavioral component in the sleep and trying to sleep well in a timed manner with all that, accompanied by physiology, so 2 to 3 weeks should be enough to last.
Yeah, I think that's what we usually tell the climbers, summiters who have just done their acclimatization hike and wanted to come to Kathmandu for their relaxation time.
Yeah,
So
and also
we'll be taking one last question. Yeah.
it doesn't give you a license again to not to listen to your body. Okay, I was 2 weeks ago at Everest Base Camp. I will just go within a couple of hours or in a helicopter and land at Everest Base Camp. You might just putting at risk yourself. The key is always, Dr. Basnet told us to listen to our body, how we are feeling. And uh, sometimes we fail to do that, and with the interest and the zeal and ego, we are all like, there is peer pressure. Oh, I might be called a weak person if I tell my symptoms, and then it might be too late when cerebral edema and pulmonary edema comes, and there will be risk. Yeah.
Yeah, I think safe ascent is always the best to avoid these symptoms of AMS and altitude illness. So one last question. So we have a question. She mentions that if someone has mild respiratory distress, or she has had an anemia that could not be corrected because of lack of time, uh, what strategy would you suggest to that person so that he or she would not get this altitude illness?
Just to rephrase, at low altitude, they have respiratory distress and anemia,
Yeah.
and they want to go to altitude.
Yes.
Uh, yeah, it depends. If somebody has respiratory distress, probably that will be the red flag. Anemia, I wouldn't be comfortable. I would probably work out why that is, and probably it would be advisable not to uh, go at altitude. Also depends on how high they are going. If you are just going in Nagarjun Dada and or somewhere in the around Kathmandu, probably it's okay if there is a rapid evacuation or transportation. But I wouldn't adventure in the Himalayas. To anemia, it depends on how low it is, what is the cause. If it is in lower end of normal spectrum, and which may not qualify for, will not qualify for anemia, that should be okay. But if it is too low, the hemoglobin, probably that is also not great to do that. Even if you go, probably slow ascent and um, would be the chance. And also prevention strategies should be there in place.
Yeah. So I think like apart from the acclimatization strategy, listening to your body would be the best if you had to go anyway.
Yeah,
So
obviously you can use prevention drugs like acetazolamide and all that, if you are not allergic to the sulfur drug and all. And Suraj, I think there is a direct DM question to me. How appropriate and commonly used is dexamethasone for the prevention, not for therapeutic purposes of AMS haze in travelers ascending to altitude? From Ayush Avasti. Yeah, Ayush, I think not much in the realms of trekkers, but people who are climbing, who are hardcore climbers, Everest and above, they might be using. There are people who are very well versed. They know what they are doing. They have been there, and they do research themselves. They use. Actually, I think Sanjeev Vandari or someone else wrote about misuse of dexamethasone by some of these climbers. They use quite often. It has been abused drug as well. Some of the climbers abuse as well. So, but what I would say that if you had a previous HAPE, and you have absolutely a reason to go altitude, I would take dexamethasone as a prevention drugs because it's such a great drug. But for the among trekkers, obviously safer, cheap, easier drugs are those acetylzolamides.
I would
hope
like
I
to
answered you.
I'd like to add one more thing on that regarding dexamethasone for prevention strategy. Those with sulfa allergies who cannot take acetazolamide, they can use dexamethasone. Also, those who are climbing very rapidly, such as the army who has to go up there and then do the rescue missions, who don't have time to acclimatize. For the rapid ascent, sometimes dexamethasone is recommended because acetazolamide it takes time to act upon.
That's right. Thank you, Suman. Kamal, you can add anything?
Dr. Kamal is asking if there are any roles of iron supplementation for those patients with anemia to prevent AMS.
I can't think of that anything, but obviously, if there are any insights on iron supplementation, yeah, Kamal, I think this iron hemoglobin altitude has been very hot topic in last few years, almost last decade or so. I think there have been some discussions about WHO criteria is also being misleading for this iron content at altitude. And there was also research from Peter Robbins from Oxford. Actually, he is the leader in iron at altitude. He said that if you have a good iron in, if you have iron there, no iron deficiency or iron deficiency, there have been iron deficiency which leads to the hypoxic pulmonary vasoconstrictions more, and it might put you at risk of high altitude pulmonary edema. So almost like iron can be so that can be marker. So anemia, those people who are anemia should be careful on that basis. Obviously, then oxygen content and transport is also at risk. So yeah, so the iron you have to be careful. The basic cross. There was a JAMA publication from Peter Robbins' team that doing an iron infusion, even chronic mountain sickness and a high pulmonary pressure, artery pressure, and they had shown, I think, the infusion has lowered the pulmonary artery pressure. So
Okay, I think there are no promising research proven for iron. There was some discussion in the previous ISMM World Congress that iron might help, and it had some role in hypoxia-inducible factor gene as well. So I was not very sure. Sorry,
no,
I was intermittent on and off as I have some other responsibilities. Thank you, Matidai, for clarifying.
Yeah, I think this is very, very important, Kamal, and there have been research and hemoglobin concentration at altitude and all that. Obviously, Cynthia Bill's study and their breakthroughs came from hemoglobin. And still, for acute pathophysiological and clinical perspective, there is no kind of like, the punchline research there for addressing this acute emergency and altitude illnesses.
Thank you.
So I think we are almost in the end of this session. We'll have another session in about 3 months time for now. So if you guys have any topics that you want us to discuss or any speaker that you want us to bring to our Himali Sambad, please text us in our Mountain Medicine Society's messenger group, or you can email us in our Google group. So I would want to thank Dr. Matiram sir for his time and for his valuable insights into the physiology of altitude and the pathophysiology of acute mountain sickness and related high altitude illness. Also, I want to thank all the participants for the engaging discussions and bringing up some very brilliant questions. So if you guys do not have any questions, we'll end it here and see you again in the next 3 months.
Yeah, Suraj, there is a very good insight from Sundar, Dr. Sundar, about Kailash Mansarovar's trip. This has been a recurring phenomenon in Kailash Mansarovar and also in Gosai Kund. The problem is, you guys are doctors, so you are prepared. Most of these our pilgrims are very unprepared. They are not trekkers. They don't have good clothes, shoes prepared for this. They just are doing a pilgrimage, and obviously they have their own cultural and a little bit of religious beliefs on what to do, what not to do during that, and also taking bath dips in this Gosai Kund and suffer from hypothermia. The holy grail and the crux lies in the and the prevention, acclimatization, and doing preventive drugs. Probably, I don't know how long before you started, Sundar. Maybe you start 1 day or 2 day, 1.5 day earlier drug before going there, right from Kathmandu. You might have started drugs late. One, two. Obviously, these most of these ascent profiles are very, very fast. So drugs might not be able to fix that.
I think I have a question to Sundar. Were they actually acclimatized or not? Because I think he works in Jumla, and a bunch of people from Jumla, Karnali Academy of Health Science, they went to Kailash in a jeep very rapidly. I was in Humla recently, and what I got to know was people from sea level, from Nepalganj, they fly to Humla at 3,000 meters, immediately take jeep, go to Hilsa, above at and around 4,000 meters. That's a super rapid ascent to get all these symptoms. So I'm curious to know from Sundar whether they were acclimatized or not.
Dr. Sundar, maybe it would be better if you can, like speak up rather than just type.
Yeah, I am little bit in a maybe a noisy place. That's why I had choose to text actually. So I realized that we everybody has realized that our accent was a little bit rapid. But my query was not about the accent, about that food. We are not able to like get maybe like there is trend of using a boteja, very like oil, ghee, and very salty, and like maybe whatever type of food we usually get in our place, their food is totally different, and we are not able to like digest and take the food that is prevalent there. So my query is like what type of food is more suitable in such high altitude? is there any recommendation like whether to take high salt or low salt, or any is there any recommendation or practices, something like that? We everybody realized that we had extend a little bit rapidly because we went there for another purpose, like for a health camp. No, actually, climbing, going to Mount Kailash was our secondary goal. So primary goal was health camp. So we had to keep Mount Kailash as a secondary priority. So we had realized we had we are in a time constant. So I accept our accent was little bit rapid. So most of us had to descend at that time. But regarding food, everyone is having difficulty to adjust with food also. So any regarding food, any recommendation or so I want to hear about that.
For this, I don't have much to add because I think what I know is all of you guys know. Suman and Kamal and Suraj can add on this.
Yes,
And
I can jump in here. With gain in altitude, our appetite gets decreased because of this anti-appetite biochemical things gets released in our body. Our appetite gets goes down, but there are no food that helps us with acclimatizing with high altitude. There are many foods that people take around the globe in Nepal and in Himalayan region. They take garlic, ginger, like many things, black pepper and things. In South America, they take cocoa leaves, and around the world there they take many foods that are available to them, but there are no studies that has shown any benefit in regarding to acclimatization with high altitude. I would say the hydration is very important, because when we are taking acetazolamide, we are diuresing bicarbonate, and for that we have to take a good amount of water. Another thing is, when we go to high altitude, we also tends to get more amount of like acute gastroenteritis because of the hygiene and things. So cooked food, cooked healthy food, and adequate hydration is the key. There are no food that helps us with acclimatization to high altitude. At least there are no studies yet to support food that associates with acclimatization.
yeah, I agree, Suman. And I also didn't want to add because you guys know, the easily digestible and well cooked food is good. I mean, the old, our staple diet, dal bhat, tarkari, probably that's the best. But our colleagues, friends from Feriche might be bored to death about these foreigners who are we serve dal bhat rice 3 times a day. All of my friends get so bored. This.
We have a great cook this time. There's a lots of variety in food.
So
Yeah. Otherwise,